Welcome to 6NDA. I'm Chao-Wei Hwang from the Johns Hopkins University School of Medicine and from the Frederick Health Hospital. Today's case is a case of dual coronary perforations. Our patient is a 60-year-old man who has not seen a physician in many years. He developed chest pain about a week ago, but decided not to seek medical care at the time. Unfortunately, he had several hours of recurrent chest pain and then presented to our emergency room. In the ER, his ECG was notable to have inferior ST segment elevations. The STEMI team was activated. He received aspirin, ticagrelor, and a heparin bolus, and was referred for emergency coronary angiography and PCI. On diagnostic angiogram, the LAD had some mild to moderate disease in its mid and distal sections. The circumflex had some moderate plaque in its midsection, as well as some osteal disease in the second obtuse marginal branch. The left main coronary artery was without any significant disease. The culprit was the right coronary artery, which was 100% occluded in its midsection with TIMI zero flow. We attempted to wire with a workhorse BMW wire. However, the BMW wire could not cross, which usually suggests that the thrombus was organized. However, a hydrophilic wire would cross relatively easily. We performed a balloon angioplasty with a 2.5 by 12 millimeter compliant balloon, and after angioplasty, you'll notice that the TIMI3 flow was restored. There is some residual thrombus in the midsection of the RCA. We went ahead and deployed a 3.0 by 23 millimeter drug-eluting stent. And post-stent, there was some vasospasm in the distal RCA, distal to the stented segment, which resolved quite readily after infusion of intracoronary vasodilator. The final result was quite satisfactory. There was TIMI3 flow in the RCA. There was somewhat sluggish flow in the right ventricular marginal branch, but the patient was normotensive at that point and relatively stable. We did advise the ICU to watch for RV infarct physiology in the next several hours, however. In the ICU, his initial troponin was 10.2 nanograms per mil, which again is consistent with what is likely to be a late presenting MI. He had a persistent inferior ST elevation as well as persistent mild chest pain, but it was stable and not worsening. He became somewhat hypotensive, but that was initially felt to be expected, as we thought that he had likely RV infarction physiology. He was aggressively fluid resuscitated, but despite that, he remained hypotensive, so vasopressors were added, and which was titrated upwards. As the time went on, he became increasingly dyspneic. He also became more and more tachycardic to as high as the 120s. So we went ahead and ordered an echocardiogram, and which here clearly you see that there is a very moderate to large pericardial effusion, which caused some degree of tamponade physiology with RV collapse. He was moved to the Cath lab then for emergency pericardiocentesis, which was done from a subxiphoid approach, and we were able to evacuate 550 cc's of bloody pericardial fluid. The pericardial drain was left in place. After pericardiocentesis, he was still hypotensive, so a balloon pump was placed. So the question is, what actually caused the pericardial effusion and for the patient to go into tamponade? Because of his late presenting MI, we were actually worried about a slow free wall rupture. And this is the echo that was done after pericardiocentesis, you see that the effusion has basically been completely drained. However, surprisingly enough, we saw a ventricular septal defect here. But VSDs don't typically cause an effusion. We were still attributing and hypothesizing that he might have a free wall rupture as well. Again, the other post-mechanical complication is a papillary muscle rupture and a wide open MR, which the patient actually did not have. So at this point, we were hypothesizing that he had two mechanical complications, a VSD as well as a free wall rupture. This would be an unusual event, but in any case, we were making arrangements for emergency transfer to a tertiary center. At this point, we took a look at the post-PCI angiogram from earlier in the day. If you look downstream here, you'll see what looks like blush, but is that actually blush, or is that something else? Could it be a perforation? So the patient was already in a cath table, so we decided to shoot his coronaries again. And here's the relook angiogram. And here it's pretty clear that in this area there is clearly a perforation. We thought that there was probably wire-mediated, as the PCI was performed using the hydrophilic pilot 50 wire. So there are several ways of classifying coronary perforation. The most common one is the Ellis classification, which classifies perforations into how deep and how large the perforation is. Type 1 is essentially a crater, but there is no extravasation. Type 2 is a little bit deeper, causing a pericardial or myocardial blush, but also without the extravasation. Type 3 is when you actually see extravasation, and type 3 cavity spilling, and sometimes also called type 4, is where there's frank perforation with blood spilling into another cavity, such as a ventricular chamber, or the pericardial space, or a coronary sinus. So how do you approach a coronary perforation? First, keep calm. Second, you got to stop the bleed. You got to inflate a balloon to occlude the blood vessel. You take a balloon that's matched 1:1 to the vessel diameter. You blow it up at low atmospheres, and you keep it up, prolonged, for up to 10 to 15 minutes. You call for help. You get a stat echo. You alert your cardiac surgical colleagues. If needed, you got to support the blood pressure. You give intravenous fluids, and you give vasopressors if they're still hypotensive. If the patient is in shock or if there's tamponade, you got to perform emergency pericardiocentesis. If there's a lot of fluid, if the perforation is large, you have to transfuse the patients with blood, and sometimes you can perform autotransfusion where the blood that you get from the pericardial effusion is directly given back to the patient. Occasionally this is done with a direct connection from the pericardial drain into a femoral sheath. Next, you got to fix the problem. Now, very often the prolonged balloon inflation will often fix the problem and seal the perforation. If the vessel doesn't seal with prolonged balloon inflations, then you got to move on to other strategies. If the vessel is large, then you typically would reach for a covered stent. Now, in the United States, there are two covered stent systems that are available. The first is the Graftmaster stent sandwich, and the second is the newer PK Papyrus single-layered stent system. Now, the thing to remember is the Graftmaster is bulkier, has a much larger crossing profile than the PK Papyrus. Nevertheless, for up to a 4.0 millimeter Graftmaster, 6 French guide is sufficient. For the larger stents, the 4.5 and 4.8 millimeter stents, a 7 French guide will be required. The PK Papyrus will fit through a 5 French guide unless you're talking about the 4.5 or 5.0 millimeter stents, which will require a 6 French guide. Now, delivering these covered stents can be somewhat problematic because you want to try to minimize the time that you deflate the balloon that is sealing off your perforation. The most common technique is just a single guide technique. That's when you essentially deflate the balloon, take it out, and very quickly, as quick as you can, put in the cover stent over the same guide and the same guide wire. You usually have to take out the balloon before putting in the covered stent, as the stents are so bulky that you're not going to be able to have you're not going to usually be able to have the balloon and the stent within the same guide catheter. The main drawback for this technique, obviously, is that you got to take the balloon out and put another stent in, and at that time, there could be quite a significant amount of extravasation through your perforation. An alternative technique is called the double guide technique, or the ping pong technique, and that's illustrated here. In this technique, you essentially insert a second guiding catheter, and I usually recommend a 7 French catheter at this point to give you more options. You keep the balloon inflated. You get your second guide catheter engaged in the same blood vessel. You wire it. You quickly deflate the balloon to allow you to pass the guide wire across the lesion. As the guide wire passes, you reinflate the balloon, and that gives you time to pass your covered stent over the second guide wire. Once your stent is in position, you then deflate the balloon, withdraw it, and then deploy the stent at the perforation site. Using the double guide ping pong technique will tend to decrease the time that your tamponading balloon is deflated and minimize extravasation. Now, if it's a small vessel perforation or a distal perforation, typically the techniques involve embolization because usually these vessels are too small for covered stents. And there are several options for embolization. The most common ones to use coils. And the thing to remember about coils is that most coils are not compatible with 014 microcatheters. In our practice, we typically use the Cordis Rapid Transit 018 microcatheter. To actually position the coil, you advance your microcatheter over a regular guide wire into the target vessel that you want to coil. If you're going to use a pushable coil like the Vortex 18, you insert the coil using their delivery device into the microcatheter, and the coil is then pushed along with just a regular workhorse wire to the target. Now, the thing about pushable coils is that they are not retrievable once they are delivered, so they have to be positioned very carefully. There are also detachable and retrievable coils, such as the Axiom coil, that are also available. Now, these are examples of some coils. These are pushable coils from Boston Scientific. This is a Vortex coil that literally looks like a coil, and there are also straight coils types as well. They come in a package that look like this one. The coil is actually sitting within this little introducer. You take out this holder, and then you use this device to essentially push the coil into your microcatheter, and then once it's in the microcatheter, you advance your workhorse wire to push that coil into the target vessel. Now, if coils are not available, you can also embolize the patient's own fat or clot to seal the distal perforation. And the way this is done is the fat or the clot is harvested from the patient. Usually for fat, you take a little piece from the arteriotomy, you trim it to size, you insert it into the microcatheter that you've previously positioned in the target vessel, and you deliver the fat or the clot by flushing it forward with saline. Now, besides embolization, another strategy would be to use a covered stent in the main branch that would exclude the small perforated vessel. Other options include using thrombin or polyvinyl alcohol, although these are much less frequently used. If despite all this you still have persistent extravasation, then you got to call cardiac surgery to take him to the OR. You would support the blood pressure either with fluids pressors as needed, transfusion, hemodynamic support, and at that point you would reverse anticoagulation I usually do not reverse anticoagulation until all equipment is out of the coronary artery, because otherwise you can potentially run into catastrophic vessel thrombosis. If you're going to reverse, the typical protocol is to use protamine at the 1 milligram per 100 units of heparin dose, up to a maximum of 50 milligrams. All right, so back to our patient. We wired the perforated branch, and we inflated a compliant balloon to occlude the perforation. But after we did that, we actually noticed that there was a second perforation up here. And you'll also notice that there is a blinking appearance to this branch, which is happening because of contrast being washed out into the pericardial space. After we deflated the first balloon, it unfortunately was not sealed with balloon tamponade. It actually continued to have a significant amount of extravasation. So we went ahead and inflated balloons in both branches and kept them inflated for about 15 minutes. But despite that, neither perforation was sealed. You can see that both perforations are still present with a significant amount of contrast extravasation. So what is our strategy in this point? We thought about perhaps doing a covered stent, but you can't do a covered stent down here. It's far too small. We thought about excluding this entire right posterolateral system by putting a covered stent from the distal RCA into the PDA, but that seemed like it would be sacrificing a lot of territory. So what we decided to do is we decided to use two strategies. We decided to actually go ahead and coil this larger branch and then use a cover stent here to exclude this smaller branch. So this is the 2.8 by 16 millimeter Graftmaster stent, which we positioned distal to the origin of this right posterolateral branch, but covering the mouth of the smaller branch. Graftmaster was deployed, and you see that you can't see the smaller branch anymore, having been successfully excluded. We then advanced a rapid transit microcatheter into the larger branch, and we made sure that we were selecting the right branch by doing a contrast injection. And we went ahead and deployed a coil. The first coil we actually deployed was a straight 2 millimeter coil, which is this one down here. And that was far too small, and it actually embolized distal to where we thought the perforation was. We then sent down a Vortex 18 3 by 2.5 millimeter pushable coil, which is this, and that lodged itself proximal to the site of perforation. But you can see that actually immediately after we delivered the coil, the perforation was not completely sealed, and that's actually relatively common. It takes a little bit of time for the perforation to seal. We took out the equipment, anticoagulation was reversed, and on the subsequent shot, you'll notice that both branches were successfully sealed. The patient at this point was airlifted to the tertiary center for management of the VSD. So what are the take-home messages? Well, number one is to try to avoid perforations in the first place. Be careful using hydrophilic wires for PCI. We advise that once the lesion is crossed, that it be swapped out to a more gentle workhorse wire. If you do get a perforation, number one, keep calm. Number two, inflate the balloon to occlude the vessel. Number three, call for help, get an echo, alert surgery. If needed, support blood pressure. That means intravenous fluid, blood transfusions if necessary, pressors if necessary, and pericardiocentesis if necessary. Next, you got to fix the problem. And oftentimes the prolonged balloon inflation itself will fix the problem. But if that doesn't work, then for large vessels, think about using a covered stent. For small vessels, think about embolization, either using coils, using a fat specimen, or clot. Once the equipment is out, reverse anticoagulation, and if needed, call surgery. All right, thank you for watching. If you enjoyed this video, please subscribe to the channel by clicking on the button below. Thank you.